So welcome everyone to the second webinar from our four-part series, Rheumatology Revealed, updates on common diseases and referral tips for family physicians, hosted by our Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Scher, and I'm the Associate Dean for the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. So I'd like to acknowledge the University of Alberta. Its buildings, labs, research stations are primarily located on the territory of the Nihao, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as parts of Treaties 6, 7, and 8 and the homeland of the Métis. And the University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I myself am a colonial settler here since 2009, originally from New Brunswick, Nova Scotia. I put in here the link to the recent CMA apology to Indigenous peoples, which I think is really amazing and powerful. So we're just wanting to highlight that and use it as a place for reflection. So for this webinar series, just want to reiterate for those of you who may not have joined us before that if you have questions for the team or technical difficulties, please use the chat feature on the bottom of your screen. But if you have questions for Dr. Akbar, please use the Q&A box and please try to put your questions in there. We'll be moderating those. If there's a question that's been asked that you really want to have answered, please upvote those questions because we can't guarantee that we'll be able to get to all of the questions. A recording of the webinar and a Pearls for Practice document with resources will be sent by email to all those that registered. So exciting with this series. We're having such great registration. So you'll receive that. The ones from last week are going out this week. And if you scan this QR code, you can get to the My Lifelong Learning Plan tool, which is free. And you can earn some Main Pro Plus credits using that tool. As well, if you're Main Pro Plus participant, you can do a linking learning exercise and earn some certified credits with that. Okay, so thanks very much, Andrea. So I just want to introduce Dr. Shafiq Akbar. We're just so pleased to welcome her with us today to learn all about osteoarthritis, common practices compared to clinical guidelines. Dr. Akbar is an Edmonton-based rheumatologist and an associate clinical professor in the Department of Medicine here at the University of Alberta, celebrating the 100th anniversary this week. So exciting. She graduated from the University of Karachi in Pakistan and then completed her residencies in internal medicine and rheumatology here at the University of Alberta. She's been a principal and sub-investigator for multiple clinical research studies for rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis for different biologics and JAK inhibitor therapies. And she's actively involved in teaching at every level, medical students, residents, fellows, and is a mentor for medical students. She's also conducted outreach clinics in rheumatology at the Fort McMurray Hospital. So Dr. Akbar, thank you so much for joining us today. And I'm going to turn it over to you to share your screen and teach us all about osteoarthritis.
Okay, thank you so much. Can you see my screen?
Yeah, we can. Perfect.
Just give me a second. Still the screen?
Yes.
Okay, good, excellent. Thank you so much, Denise. And I would also like to thank Andrea for allowing Rheumatology to participate in this webinar series of 4 talks with some of the important rheumatological conditions that might be of use for family physicians and general practitioners. And I think introduction is already done. Thanks for that. And I would like to thank you all for taking out time to attend this talk during your precious lunch hour, which is always tough to do. And so we will move on. For this presentation, I do not have any disclosures, but I have participated for multiple pharmaceutical companies in research as well as for presentation and advisory board. So my topic today is joint effort, OA management, common practices versus clinical guidelines. If I'm going too fast or too loud, please let me know. And my objectives are just to briefly review osteoarthritis and review the osteoarthritis management through the ACR, or the American College of Rheumatology guidelines from 2019, and a brief discussion about the investigational products that are there in the pipeline as well. And the other thing I think for this webinar is to give you the referral tips for rheumatology, but I did not make it my objective, but we can discuss it at the end of the talk. As I mean, I would need your input. What are the things that you would like to address? Okay, so before we move forward, there is a question for you. How many people suffered from osteoarthritis in 2020? So just think, what do you think? Is it 100 million, 250 million, or over 500 million? Well, excellent. I think most of you know osteoarthritis very well. Excellent. So it's over 500 million people that are suffering from osteoarthritis. So there's a recent report on Lancet that was published in 2023. So globally, at that time in 2020, there was like 595 million people that suffered from osteoarthritis. That is around 8% of the global population, and that has increased like 132% from 1990. And as you know, osteoarthritis is a chronic disease in the sense that it runs over decades, right? So the number of people who will be affected by osteoarthritis is going to increase as time passes, and as a result, it causes a huge economic burden on the society. And osteoarthritis is considered as the seventh leading cause for years lived with disability. So this is a condition that is associated with a lot of disability. And actually, WHO designated 2021 to 2030, this decade, as decade of healthy aging, and emphasizing on life expectancy, but in addition to that, the quality of life. So if we start working on osteoarthritis, preventative measures that we can do in order to make it better, that at least we can somehow mitigate the, say, disability associated with osteoarthritis in the long run, hopefully. So osteoarthritis is simply a degenerative disease due to wear and tear. What do you think this is a correct statement? Excellent. As I said, you guys know it. So osteoarthritis is considered as generally considered as a wear and tear type of arthritis. But the thing is that now that we have more information about the pathology and underlying reason for osteoarthritis, so there's a little bit of inflammatory component attached to it. So it's correctly named as osteoarthritis, although the degree of inflammation would not be the same as you would see with other inflammatory conditions, but there is some. So with regards to epidemiology of osteoarthritis, it all depends, like how do you, when we are thinking about osteoarthritis, is more so is a disease of older generation, right? So when you are looking at it, so if you look at people under the age of 45, there's a little bit more, prevalence is a little bit higher in men as compared to women. But over the age of 45, women are more likely to have it as compared to men. And then osteoarthritis also varies by race and ethnicity. So I don't know if you've heard, or you have read about it, that Asian women tend to have less osteoarthritis in hip and knee OA, and African American ladies have more osteoarthritis. And I mean, so there is a little bit of difference. Now, which is the strongest risk factor for osteoarthritis? All three listed below, obesity, age, and female sex, are risk factors, but which is the strongest? Excellent. So aging is the strongest risk factor for osteoarthritis. That's absolutely correct. Obesity is another big one, and I mean, hip and knee OA are pretty prevalent, and then osteoarthritis of the hand and the other joints. And so when you think about osteoarthritis, the two major things that come to your mind is one is the joint pain as well as the functional impairment. And I think we see that on a very consistent, regular basis that patients have a lot of physical impairment because of osteoarthritis. And as I said, it's an it's a disease of the entire joint rather than just the joint itself. So the structure surrounding the joint, everything is involved, and we'll discuss about it a little bit in the pathology of osteoarthritis. And of course, when you have disability as a result of joint pain, it is going to affect your mood and your physical, and it will cause physical limitations. So in social activities, everything would be affected with osteoarthritis. So osteoarthritis is the most common form of arthritis that we deal with. But the problem is that most of the time, I think the major brunt of osteoarthritis is on family physician or general practitioners, because I shouldn't be saying it, but it's very common that we say that, okay, osteoarthritis, we won't follow up with this patient because we all know that there's not much to offer in osteoarthritis. But if we work on things that can prevent or can do other things that might be beneficial. And if you have to define osteoarthritis, it can be defined on multiple ways or on the basis of imaging. You can define it on the basis of clinical symptoms of the patient as well. And now that we are coming up with newer, or I would say more sophisticated investigations, including the MRI and the CT scans, we can understand the pathology as well as I think the definition of osteoarthritis is going to evolve. And other thing is that is osteoarthritis associated with, does it cause increased risk of mortality? And so there is some association. Some of the studies have shown that there is some association between osteoarthritis and mortality. And the mortality is, but some of the studies did not confirm it, so but it is there. And the mortality is generally on the basis of obesity. So there are lots of things. So you have cardiovascular risk factors, diabetics, high BMI, smoking, but the things that are mostly associated with osteoarthritis leading to mortality is obesity and elevated CRP. So a little bit of low-grade inflammation can contribute to that. Oh, sorry. So with regards to pathology of osteoarthritis, so as I said, it is the involvement of the entire joint and the surrounding structure. So most of the time it is because of the improper load on the joint. And as a result, you get the underlying tissue gets damaged, and that leads to more proteolytic enzymes or pro-inflammatory enzymes, and that leads to joint destruction. But the degree of inflammation is not the same as with rheumatoid arthritis or other inflammatory arthritis. If you look at the cell count, if we aspirate a joint and if you look at the cell count would be somewhere under 2,000 WBCs. And again, we can further divide them into what kind of cell is present in the tissue, in the synovium or synovial fluid. It would be more so macrophages rather than neutrophils that we see with inflammatory arthritis. And this is just, if you look at, say, histologically, then of course you have the cartilage cartilage framework is affected. There will be loosening of it. There was some edema in it, and the degradative enzymes will be there, and the chondrocytes are affected. And so then you ultimately get the fishing and the cracking in the joints. And when you have more of damage to the cartilage. As a result, we'll go into it later that on the imaging, you can see the space, which what we call it as joint space, where you have the cartilage that get thins out because of the damage to the cartilage. And when the body tries to repair the bone, as a result, you get the new bone formation that is in the form of osteophytes. And even the osteophytes are very tiny, but when you look at, suppose if you're looking at the knee joint of a patient, you can see the difference between the normal knee and the osteoarthritis, arthritis related knee. There would be a difference in the size of the joint because of these tiny osteophytes that makes the joint look a little bit bigger, as well as it's not like properly aligned, so that may make it a little bit bigger as well. So this is just a pictorial view of what happens on the left-hand side of the screen. You can see the normal cartilage with a very smooth outline and the underlying structures, where on the right-hand side at the bottom, you see the cartilage is broken, there's fissuring, and you see the edema and subchondral bone thickening. And so when we are talking about osteoarthritis, so there are two types of osteoarthritis in general. It could be primary osteoarthritis, or you could have secondary osteoarthritis. So primary osteoarthritis is when you do not have any underlying risk factors for osteoarthritis that could be the cause of secondary osteoarthritis. Most of the time, osteoarthritis affects the DIP and the PIP joints of the hands and the CMC joint. Now, the same distribution can be associated with another type of osteoarthritis that we call as inflammatory osteoarthritis. And this is much more aggressive. It's much more common in women, and it may progress very quickly, and then it calms down and it can flare again. And these patients, you may see a little bit of swelling over the PIP and the DIP as well. So sometimes when you have these patients, you might have an difficulty in figuring out if these patients have osteoarthritis or do they have rheumatoid arthritis. Just to let you know, so the primary joints for osteoarthritis are the DIPs, PIPs, CMC, and so the joints that are not commonly affected in osteoarthritis are your MCPs, your wrist joint, shoulder, and your most of the, second to five MTPs, excluding the first one, and the ankles. These are the joints that are not affected by osteoarthritis. And if they are affected, it could be either secondary osteoarthritis or it could be an inflammatory. So if your patient is presenting with that, then you have to be thinking about other inflammatory conditions. Or patients can have involvement of the first MTP, which is very common, and hip and knee OA. In addition, there is a form that we call it as Sjogren syndrome, in which you have generalized osteoarthritis. So in those patients, you have more than four or more than four areas of body that are affected. So it could be the spine, the knee, the hands, the feet. And so that's what is called as Sjogren syndrome or generalized osteoarthritis. Then secondary osteoarthritis is basically when you have an additional cause. So some may have mechanical reasons because of congenital malformations. You can have dysplasias, you can have leg discrepancy, or you can have, so if you remember that previously they used to go in a lot in the knee joints and they used to fix the cartilage and whenever somebody has a little bit of OA. So, but now they have stopped doing it because they figured out that more you take out the cartilage, the more you are more prone to osteoarthritis. So the knee debridements are not in trend anymore, I would say, because that leads to secondary osteoarthritis. Then endocrine conditions, hyperparathyroidism can do it, crystal arthropathy can do it. A type of crystal, which is the pseudogout, can also be seen with like hemochromatosis. In those patients, you can have involvement of the MCP, mostly in men, with second and third MCP, but they present mostly like osteoarthritis type symptoms rather than inflammatory. And of course, if you have a diabetic patient, they can have osteoarthritis if they have Charcot's joints or something like that on the foot. And the other thing is that say if you have a septic arthritis, then of course that can lead to secondary osteoarthritis very quickly. That's why that is dealt as an emergency. Now, when are you doing the radiographic classification of osteoarthritis? It may be from zero, so there are 5 grades, so 0 being normal, that no signs of osteoarthritis, to severe osteoarthritis. Well, we didn't do the poll. I want you to find out if you guys know this the right knee or the left knee. But well, it's the left knee. So you can see on the right hand side of the X-ray, you have the fibula, and the top is the femur, and the tibia at the bottom. So at the femoral condyles, you can see there's a space between the tibia and the femur, which is known as the joint space narrowing. So on the left hand side of the picture, you see there's a little bit of narrowing of the space as compared to the right hand side, the lateral side. So that is called the joint space narrowing. And also you can appreciate in the picture that maybe I can use that. Oh, sorry. On the picture that there is osteophyte formation on the right hand side. And and yeah, so the grade 4 is when you have complete loss of joint space narrowing. There's complete loss, and it's what we call it as bone on bone kind of a thing. That is the stage 4. So next question is, do radiographic changes of osteoarthritis go hand in hand with patient's symptoms? Excellent. So yes, so the what you see on the X-ray does not go hand in hand, so that there's a great discordance between the two things. Therefore, I think it's a good time that I can tell you that most of the patients that come to our clinics, if they have done the X-rays done by family physician or ER physician or somebody, right? I mean, you see the patient comes in and they would remember each and every joint that has been affected, whether there is stenosis or sclerosis, and they want an explanation. Always explain the patient when you do an X-ray that you may see some changes, but that does not mean that is causing your symptoms. Otherwise, patients start living with the concept that, okay, their spine is so affected that it's going to crumble in a day or two, and they just try to protect it by not doing anything, which is the worst thing to do. So you're right. So they do not go hand in hand. So radiographic OA is twice as common as symptomatic osteoarthritis. So in the studies, it has shown that in all the patients on the basis of radiographic OA of the knee, they're from 14 to 37%, only 7 to 17% were symptomatic. So that is almost like 50% of what you see on X-rays versus patient symptomatology. Okay, this is another question. Does running or jogging predispose to osteoarthritis? Well, you guys are doing pretty good, so that's excellent. So running or jogging in general, if you do, I mean, you would think that okay, it's a lot of load on the joints, and so in general, runners like recreational or something like that who do running on regularly, there have been studies. There was a recent study I think published that also showed that patients who had who were runners versus the patients, the control population that was not runner, there was no difference in the risk of osteoarthritis. But if somebody is like an elite runner or something, competitive runner, they might be a little bit higher risk of osteoarthritis because they do quite severe, rigorous activities. And does cracking one's knuckle lead to osteoarthritis of the finger or fingers? Very good. So I mean, we have all come across that. We always used to say that do not crack your fingers because you're going to get osteoarthritis, but that is right. That does not lead to osteoarthritis. In fact, there was a physician who did, I mean, there are no specific randomized trials or anything like that on that, but there was a physician who did crack his left hand, all the joints daily, twice a day, and for 50 years, and there was no difference. So cracking is not a problem. And now the thing is that why do we get the cracking? Cracking, you have cracking because, I mean, the joints between the DIP or the PIP, these are tiny joints, and there is an adhesive type of seal that is formed by the synovium in those joints, and when you put pressure and try to snap it, as a result there is a sound, and there's a gas bubble that forms in that area, and hence you get the cracking. I don't know if you have noticed that if you have cracked your joint once and if you try to crack it again, it won't crack, because the thing is that the gas bubble has to take, it takes about 30 minutes to reform or get absorbed, and then you can crack it again. Now, with regards to management of osteoarthritis, again, it's a very holistic approach that we have to have. It is multifaceted. So you need the pain control, functional improvement, you need education about the disease, self-management program, and preventing any joint damage or structure changes in the joint. So, with regards to treatment, we have non-pharmacological therapies, we have pharmacological therapies, and the last resort is the surgical approaches. So far to date, we don't have any structure modifying or disease modifying medications for osteoarthritis, unfortunately. So American College of Rheumatology, in collaboration with Arthritis Foundation, they came up with a guideline in 2019, although we had a guidelines published in 2012 as well. So there's a little bit of difference between the two guidelines. So they did a systematic review, and I mean, the guidelines are here to give directions for clinicians as well as for the patients, in help them in making the treatment options or management of osteoarthritis. And patients and physicians should have a shared decision making when they are coming up with the suggestion, because you have to make into account the patient's preferences and their comorbidities. And these recommendations should not be used to limit or deny access to therapies. So these are here to guide us, but that doesn't mean that you can not change the order things are suggested. And so I don't know if you want to know about this, but this guideline was prepared by a different, a group of, say, physicians and patients, rheumatologists, internists, occupational therapists, and a patient panel. And so they did a literature review, and somebody was involved in making the PICO question and all that stuff. And so they did review all the system. They did a systematic review of all the literature in which you have the osteoarthritis of the hip, knee, or hand OA. They did not use the previous meta-analysis. They did their own review. So that's a good thing about this guideline. The other thing is that so they came up with recommendations. Either they made strong recommendations, or conditionally recommended, or strongly recommended against, and conditionally recommended against. And in the case if they did not have enough evidence to comment on one thing or the other, then they would not have any recommendations. And for every recommendation, they had to be a 70% consensus among the voting panel of members. So sorry, this slide is a little bit too much of writing on this one, but I just wanted to explain that for a stronger recommendation. So suppose if you have a strong recommendation for or against. So if all the so the course of action would apply to all or almost all of the patients, and only a small proportion of patients would not follow the recommendation. So that would be a strong recommendation, either for or against. And conditional recommendations are the one when you don't have enough evidence to say one thing or the other, or the evidence is very low, and or the risk and the benefits are pretty much the same. Then you have to have a shared decision making, especially in these types of recommendations, when you are making these recommendations. So in non-pharmacological recommendation, exercise is one of the most common one for management of hip, hand, or knee OA. And it is not uncommon that most of the patients would ask you, like, how much should I exercise and what type of exercise is the best exercise for me? But the thing is that in this guidelines, they were unable to comment like which exercise is the best one to do because they did not have enough evidence to say that. But exercises are recommended in any case. Aerobic exercises are recommended. Pool exercises are very good as well for patients because most of the patients are like overweight or obese, so they might have some physical limitations. When you are in the pool, then you don't have the weight bearing effect. So as a result, you can have a better range of motion of the joint. And then you can, I mean, you can go to the rec centers or you can use elliptical or stationary bike or indoor fitness walking. But generally, most of the people do regular walking, which is recommended. And as I said, so there's no hierarchy of these various types of exercise that you do this or the other as per the literature. And there is no uniformly accepted level of pain because people say, okay, sometimes I go for physiotherapy, I have pain, so should I do it or I should not do it? So I think you have to use your common sense in the sense that try to go slow and gradually build it up. And but all exercise, I mean, all the evidence suggests that exercises are always more beneficial or have a better results if it is supervised exercise. And with regards to weight reduction, that is highly recommended weight reduction for patients who are overweight or obese. And it has a dose dependent effect on weight reduction. The more you lose, the better it is. So it is, if you have a patient in the clinic who is morbidly obese and you say that, okay, you need to lose weight, the patient won't be happy with you. And you feel a little bit reluctant or hesitant to say that because that doesn't sound like an achievable goal in the short term. So evidence has shown that even if you lose 5% of your body weight, that would have appreciable, clinically significant effect on your joints. I don't know if you know that if you are walking, you have like 3 times your body weight on the hip joint, 4 times your body weight on the knee, and 5 times on your ankle. Now you can ask that how come the ankle joint does not get osteoarthritis as a primary osteoarthritis? The reason being that the ankle joint, the way the joint is, it's more of a gliding movement rather than sideways or any. So it's a quite stable gliding movement. So as a result, it does not get primary osteoarthritis, but the knee does it because knee is not that stable of a joint. It's basically gets its stability from the surrounding structures. And if you lose 5 to 10 or more than 20%, it's more beneficial. Again, it should be accompanied by exercise program to get better results. Now, self-efficacy or self-management programs, these are the programs in which you have trained nurses or occupational therapists or a group of people that would be together. So you come up with a goal for your exercises and get an understanding of the disease and learn about the joint protective measures and fitness and exercise. So the outcomes are generally better. And in the literature, I mean, most of the evidence that they have are from small groups. They have done like these sessions like 2 to 6 times in a week, but overall they are better if they are done. I mean, it's very important to have an education in the sense that understand what osteoarthritis is, what are the outcomes, and what are the achievable goals. It's not uncommon that you see an 80-year-old lady come to your clinic and would say, oh my goodness, I just feel like an old lady. And then you don't know what to say. And so if you have an understanding that this is what is achievable and this is not achievable, then at least you would start living better, I would say. So Tai Chi is strongly recommended for knee and hip OA. And as you know, this is a Chinese mind and body practice, and it has been there for a long time. And there's some special moves and breathing exercises. And Tai Chi is very good for balance as well as it helps with depression and self-efficacy as well. And I think the older patients do like Tai Chi, so that should be recommended. And there's evidence for its benefit. Now, the other thing that is similar to Tai Chi is the yoga. Now, yoga is an Indian philosophy. It's very old as well. And but it is recommended for knee osteoarthritis. The problem is that in yoga, we did not have enough evidence to say that this particular type of yoga is done. Or the thing is that all the studies or the cases that we have, they are very small number of people in it, so they did not come up with a recommendation that it's strongly recommended. But since it's very close to Tai Chi, it is conditionally recommended for knee OA. And cognitive behavior therapy, I mean, this is an important thing because it has been shown to be very beneficial in chronic pain conditions. And but because it has been useful in chronic pain, therefore it is assumed that it would be beneficial for OA as well. It is conditionally recommended that it should be done. It reduces pain and it might help with, say, mood and depression and other psych-related disorders as well. Now, assistive devices, we have canes that are strongly recommended if somebody has hip or knee OA or more than one joint. But the most important thing is, I don't know, I did not come up with the question, but I'm sure you guys know it very well, that the cane should be held in the hand opposite to your affected joint or the limb. And the other thing is the length of the height of the cane is very important. So normally the cane height should come to your wrist in order to be of proper height. And it takes off about 25 to 40% of the load from the affected joint. And tibiofemoral braces are strongly recommended in patients who have knee osteoarthritis. And I mean, there's some other things that are available through physiotherapy. You can do the kinesio taping, which is more of a tape around the joint or the patella or the CMC joint. And but again, those effects are very temporary as long as you have it. So for CMC joint, you can also use the splint for the CMC, especially when patients are doing cutting or chopping or something like that. That would be beneficial, as that would protect the joint itself for the duration. Now, some of the things are conditionally recommended against are the modified shoes with medial and lateral wedges, heel wedges that previously they were prescribed or recommended for lateral and medial in knee OA, but this has been conditionally recommended against. And now, the other things that are conditionally or strongly recommended against is massage therapy for the hip and knee OA. Well, in the hip OA, what is it going to do? It's a very well protected, deep-seated joint. And manual therapy. Actually, when I was reading this, I thought, oh, who does manual therapy? And just day before yesterday, I had a patient, older lady. She said, I was told to do manual therapy, and I've been doing lymphatic drainage therapy in the pool myself, but these are not recommended at all. Now, another modality that I think most of the people may have come across if you have done any physiotherapy for yourself is the transcutaneous electrical stimulation, which is basically sending in the electrical waves in the subcutaneous tissue and may affect the nerves. And these are like small devices that you can buy on your own as well, and people have started doing it. But the thing is that there is no uniformity in the type of devices and how much to use, what is the wavelength. So they did not come up with a recommendation. They recommended against TENS usage, although in 2012 it was conditionally recommended to use it, but now it is not recommended. And acupuncture is a very old technique. I think it's a Chinese technique as well, and it has been used for different things. But I think acupuncture became more of a thing when I think one of our journalists or something who had a chronic pain post-surgery, he went to China and he had this acupuncture done. And when he came back, he had an article in New York Times, and then people started looking into it in 1970s or 80s. And now it has become, I mean, there's evidence that it works. There's not much risk, except I think in patients who have very slim patients or very skinny thin patients, it has to be careful because it can lead to puncture in the emphysema or something like that. I think a patient of mine had it. She was very slim as well. And so, but it can be done. Thermal interventions are recommended for patients with hip and knee OA. Paraffin, you have seen it, people use it for hand OA, so that is conditionally recommended. It does help patients. And radiofrequency ablation has been used quite a bit. Now, when we go on to the pharmacological therapy, we have topical NSAIDs, which is the cornerstone of osteoarthritis. But the most important thing is that when you are prescribing NSAIDs, it has to be very short duration and the lowest possible dose. It is not uncommon that you see multiple patients come in and they say, oh, I was started on Celebrex or I was started on diclofenac for years. They have been for osteoarthritis, and then whether it works or it doesn't work, they just continue to take it. And the thing is, all the studies that have been done have shown short-term benefit for 2 or 3 weeks. So whenever you prescribe it, prescribe the lowest, but it works for all types of osteoarthritis, so majority of the patients. But again, with the NSAIDs, you have to be very careful because of the comorbidities, cardiovascular risk, kidney, liver, anything can be affected or hypertension. So you have to take care of that. Now, this is more of an, sorry, I talked a little bit about the oral NSAIDs rather than topical. Topical, you can use it with no major problem. Now, in the topical agent, capsaicin is another one that can be used, but it is conditionally recommended for knee and not for hand. The reason being that with the hand, you can have the contamination into your eye, because the way capsaicin work is that it depletes the P substance for pain in that area. So that's why. But I mean, in 2012 they did not recommend capsaicin, but this year in 2019 they did recommend for knee OA. And so we talked about the oral NSAIDs. As I said, it is very useful, but it should be the shortest possible duration and dose. And intraarticular corticosteroid injections are recommended for knee and hip OA, and conditionally recommended for hand OA. And when the hip osteoarthritis, we generally use corticosteroids. They are administered intraarticularly by radiology. We do not perform it in our clinic, but and that is what the recommendation, that you should do it under ultrasound guidance of fluoroscopy. Whereas for knee osteoarthritis, we do it always very commonly in the clinics, and it works equally. So there is no specific recommendation whether it should be done this way or the other way. And glucocorticoids injections are better than other types of injections. But one thing that I would like to say before we go further, that do not order intraarticular injections for every possible joint. Since we have this radiology, CTC and other radiology places, the patients, by the time they come to our clinic, I think they have already received injection in most of their joints, whether it works or it doesn't work. Acetaminophen is another important one, because this is what we have been saying very commonly, that you can take Tylenol as much as you want, but no, it should not be used as long as you want it, because the literature suggests that there is no major benefit after a short period. And I think the patient panel in this clinical guidelines recommended that the effect is very small on its own. If it is used as a monotherapy, it doesn't work that well. So again, you have to be careful about the comorbidities and other liver or other issues. Now, if you're looking at centrally acting agents, then duloxetine is used, and it is recommended for hip and knee OA on the basis of, there are other centrally acting medications like pregabalin, gabapentin, SSRIs, and the TCAs, but they haven't been shown to be beneficial for OA, although they may have been used for other type of chronic pain, but duloxetine is the only one that you can use in cases if you absolutely need it. Now, sorry, I'm going a little bit fast because we are running short of time. So with regards to opioids, it should not be used for osteoarthritis in routine, but of course you will have a certain patient population, those who have chronic conditions, they cannot go for knee replacement or the hip replacement or end stage osteoarthritis, or they have other comorbidities that you cannot use anti-inflammatory, or they have diabetes, right? In case if you have to use it, then use the tramadol rather than other opioids. But even with tramadol, there is risk of fall and dizziness in these patients. Now, some of the factors that have been conditionally recommended against, colchicine does not work for osteoarthritis. It works for very active arthritis in like a gout or something, which is very inflammatory, so it should not be used. Fish oil, vitamin D, bisphosphonates are strongly recommended against. Most of the studies with vitamin D have been negative, but we do recommend it for general bone health, but not for osteoarthritis. Hyaluronic acid has been used for osteoarthritis. It is conditionally recommended against in the knee and the CMC OA, but in the hip OA, it is strongly recommended against. And again, we don't know what the preparations are better and which is going to work. But the thing is that in reality, you see, most of the patients do not benefit. Most of the patients cannot, afford it either. But there's no specific major side effect, except that sometimes they can have a flare like a pseudogout kind of a thing with this medication. Now, Botox injections are not recommended because Botox works by affecting the nerve cell membranes, right? So it would take away the pain. But on the other hand, it can also cause the paralysis of the muscles or the weakening of the muscles. So you don't want that for knee or any other joint to be affected because that can lead to further issues. Now, glucosamine is one of the most commonly used, I think, agents of health products, natural products, but it is not recommended. Neither is chondroitin sulfate. Sometimes glucosamine can cause increased blood sugars, but people and some patients do like it. I don't think there's any major downside, but it doesn't show any major benefit either. Hydroxychloroquine, methotrexate, not recommended. Stem cell, we do not recommend stem cells because there is not much benefit. It is being studied still, but there are different ways of getting the stem cells and inject and using it. So there's no definitive evidence at this point to suggest. Just to give you an idea about the investigational products, there are tons of them, but the thing is that so far none of the agents have been beneficial. I can just for pain modification, you can have you can either use nerve growth factor or the nerves in the joints. So one of the nerve growth factor, tenazimab, was studied, but since 2010 it has been on hold because it really led to very progressive OA and osteonecrosis. And there's another one, fasinumab, that has been done, but that trial is also on hold. I don't know, just let me know if you want to stop now, we can. If we have questions, or if there are no questions, then we can carry on.
We've got a few questions, Shafiq. So maybe did you have any other this is fantastic.
I mean, the only other thing that I wanted, PRP is not recommended either.
Okay.
Oh, good.
Fantastic. Yeah, no, such an interesting thing. So maybe we should pop into the let's pop into the questions.
Okay.
Being mindful of there's so much to cover here. So Anton is asking how often, should those glucocorticoid or could those glucocorticoid injections be repeated?
Okay.
You're working on function.
So the thing is about the cortisone injections, again, the evidence did not, they did not have enough evidence to say which type is better, whether the long acting or the short acting. And there was one study in which it said that maybe it leads to joint space narrowing or the damage to the joint, but statistically, they were not able to say that, okay, the joint space narrowing is actually causing change to the patient symptomatology. So general recommendation is that you can take 3 to 4 injections in a year, 3 to 4 months apart. But the most important thing is that if the patient is responding, if you give the injections and the patient comes back and say the effect lasted for 2 weeks or 1 month, it's not worth repeating it. So then don't repeat it. But if the patient has like good effect for 6 months or 1 year, then you can repeat it. But the safely, you can give 3 to 4 injections in a year in a joint. As long as it works.
And then there's another great question from Sadia that we didn't really cover yet, which was around bracing, the role of bracing in arthritis and how to choose braces, etc.
So most of the time, if you need a brace, right, it depends if you have medial joint affected of the knee and the patient, if the patient body habitus is not like too obese, they can use a brace, and that those offloader braces are like $1,000 or more to get them done. So that's another, and they are very bulky, but they do help them. And otherwise, you can use the soft braces. They are not that useful, but early osteoarthritis, you can use it. So yes, you can use the offloader brace. So the best way to do is to send the patient to one of the brace places, and they can figure out which one do they need.
And just a related comment on that around joint preservation and protection. Where can you send patients for resources on what they can do to reduce the stress on their joints?
Well, the basic thing is the weight reduction. That's number one, right? So you have to tell the patient to lose weight, which does not happen in a day, but that is the most important thing. And now there are some educational sessions through the Arthritis Society that you can just, I think there's a Arthritis Society foundation or the foundation that you can contact. But University of Alberta also runs osteoarthritis, rheumatoid arthritis, spondylitis programs, but they are not run every day. You have to have an appointment, but that is another very good resource for information.
Yeah, fantastic. And the Arthritis Society webpage is a great resource.
Mhm.
So Sadia also has a question about whether there's any role in the use of CRP um, in the diagnosis of OA and assessment of prognosis.
Okay. So for CRP, there is no role for CRP in the diagnosis of osteoarthritis because the inflammation that patients with osteoarthritis would have would be very low. So that is below the cutoff of the upper limit of normal generally. But if you have a patient that you think that is it osteoarthritis or it is inflammatory arthritis, then just to be on the safe side, you can get a CRP, and that would give you an idea. If it's very elevated, then it would be more in keeping with inflammation rather than osteoarthritis. Now, there are some patients who are very overweight or morbidly obese. They may have a little bit of elevated CRP, generally in the range of 19, 20, 30, up to 34 that I have seen. And the other thing that I've seen in Somalian patients, they do have slightly elevated CRP. I mean, don't take my word for it, but that's what my personal observation. And they may or may not have any inflammatory disease. They just have slightly elevated CRP because I think the cutoffs that we have are for Caucasians over here rather than other races. So you don't need CRP for OA unless you think that there is something wrong. Could be additional.
Fantastic. So Catherine has a really interesting comment here that in Alberta, seniors can get braces free of charge. And then it says, comma, $1,500, Catherine. So I'm assuming it's free for seniors, but I'm assuming that's for aids to daily living. Maybe you want to add a little bit of detail in there. That sounds so useful to all the participants.
Yeah, that is for the ADLs. I think there is a separate program that you can go through, but it's not like every senior does not get the coverage. Even they don't get the coverage for physiotherapy.
Oh, true enough, yeah.
Yeah, yeah,
Just a little plug through the primary care networks, there is the GLAD program as
right.
well that can be really helpful for teaching people about exercises, especially for knee and back OA.
Yeah, I
Um,
think it was stopped for some time, but it has restarted because recently I think a couple of patients came and they said that they have participated in the GLAD program and they were happy about it.
yeah, no, it's been really well received, I think.
Mhm.
Uh, Catherine, just in terms of the question about the methotrexate, there's a popular primary care conference that ran last weekend, and she's sharing that they discussed a study using methotrexate for knee and hand OA. But it sounds like from the guide, it sounds like the guidelines are saying not to use it, correct?
No, we don't use methotrexate for the knee or the hand OA. Even the biologics, right? We say that, okay, there are certain pro-inflammatory cytokines that can be released, including the TNF or IL-1 or IL-6, right? But they have done studies with, say, Humira or other biologics, anti-TNFs, injecting directly into the knee joint or the hip joint, but it hasn't shown any benefit. So generally, there is no recommendation to use methotrexate or the biologics for osteoarthritis. Now, the patients who have CPPD or hemochromatosis related, say, second and third MCP OA, sometimes, although it is considered an OS, but sometimes they can present like inflammatory arthritis, then you can treat them as, say, rheumatoid type treatment. You can try that and see if it works. And if it doesn't work, then you stop it. But
Okay.
generally, we don't.
Great. So Catherine's just sharing with the group, thanks, Catherine, that yes, the AADL, so the Alberta AIDS to Daily Living Program, and that all seniors do qualify for free braces, but they need a prescription from an MD.
Oh,
Uh,
I didn't know that either.
oh, that's fantastic. Thanks, Catherine. And actually,
Excellent.
Catherine, just to clarify, because we have a number of our nurse practitioner colleagues on the call as well. Just maybe if you can just add in if they're able to write that prescription. Now, while she's doing that, there's a few questions here about meds, Shafiq. So just in terms of Genevieve's asking how you might start dosing tramadol for OA?
Oh, that's a very good question because the thing is that I never prescribe tramadol for any of my patients because the reason is that we don't see patients with osteoarthritis. That's
Yeah.
a problem. We don't have enough space to see osteoarthritis patient in routine follow-up. So most of the time, if somebody needs a tramadol or something, it's basically managed by family physicians. That's why I said the major brunt of osteoarthritis is on the general practitioners because we have so many other patients. It's just impossible to see those patients. But the basic rule is just go as low as you can for shortest duration of time. I don't know how much you have seen. I've seen like tons of patients who are on Tylenol threes and fours, threes especially, for years and years. And they still come to you for asking for more pain management. So these should not be used because there is no efficacy in the long term. So it should be briefly used.
Yeah, sometimes I don't know, clinically, I think there's a combination of things that we might have to do, especially if we're waiting for surgery. Maybe we can use the hive mind of everybody on the call around that question. Personally, I usually start with Tramacet and then see what the daily dose of the tramadol component is, and then move it to the once daily dosing with that sort of range. Lots and lots of interactions with other medications that we prescribe though, so you always have to check your interactions. That's just my clinical experience, but let's use the hive mind and see if other colleagues have other wisdom to share. And we're getting lots of great comments here from Karen and Catherine. So the AA Deal website saying the prescription must be a physician specialist practicing medicine in the areas of physiatry, orthopedics, rheumatology, neurology, neurosurgery, peds, geriatrics, or a physician with a diploma in sports medicine from the Canadian Academy of Sports and Exercise Medicine. So that's a really helpful reflection, Karen. Thanks so much, because it just means good reason to make sure we get an opinion.
Duloxetine is another thing that you can use for end stage OA or inpatients, but again, you have to be careful. Yeah.
Yeah, no, duloxetine is also a great option. I find it really helpful for backs. Particularly.
Yeah, I mean, in back, we still have like the facet. We didn't talk about, but this guideline was not about the back, but in the back, you can have the radio frequency ablation, you can have the facet joint injected, right? So those things can be done as long as they work, but nothing should be done on a regular. I mean, there are patients who get cortisone injection requisitions on a 3 monthly basis because the thing is that the radiologists, they don't have a, I mean, I shouldn't say it, but they do recommend the patient, okay, you come back after 3 months, right? We don't want that.
Yeah.
It should be minimized. It should be minimized by all means.
Right. Okay. So I accidentally hit answered Catherine. Sorry, she put a helpful tip in there that in for the bracing, there has to have been an knee X-ray within the past 6 months. But orthotics place will accept the prescription from ortho without the X-ray if they're waiting for a sort for joint arthroplasty.
Yeah, generally they request for X-ray. Most of the time that I've sent it, they would say they'd send us a fresh X-ray.
Yeah. And Val is sharing a little bit about there's lots of other AADL tools that can be supported from OT and PT. So great point to dial in our OT PT colleagues in the outpatient setting for aids. Thanks so much, Val. A couple other questions just to squeeze in here before we have to head off in 2 minutes. Sadi, I think Dr. Akbar covered the question about the topical diclofenac and the role of capsaicin. So I'll complete that one. Mark has a question. Isn't tramadol metabolized to morphine? And if so, wouldn't morphine offer any benefit that may be had from tramadol?
So I think tramadol is a little bit safer as compared to morphine. So that's why I think they recommend it because they said rest of the other, I mean, if somebody has end stage, you have to use it. That's a different thing, right? If you don't have anything, but if you have an option, then go with tramadol.
Okay. And then Tanya is asking whether or not there's been any trials of non-inflammatory diets in osteoarthritis.
Well, non-inflammatory diet would do the same thing, right? It's a weight reduction. But there are some patients who are may not be overweight, but they say that if they take out the inflammatory diet, so the only diet that has been recommended, I mean, there's no great evidence, is the Mediterranean diet for inflammatory content, right? So they recommend you can take the Mediterranean diet if you really need it.
Okay.
Because there are lots of patients who would ask you, right, that whether like, what kind of diet. If they say that no, 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 we want a diet or they're very diet conscious, then we say that okay, you can try the Mediterranean diet.
And small little advertisement to everybody on the line. We do offer a 4 week intensive obesity course, and we'll send out the info for that. Now, last question, Margaret, last but not least, is asking, is there a maximum dose of glucocorticoids that you can give patients? I'm assuming she means intra-articularly.
So intra-articular, it all depends upon what joint are you doing it, right? If it's a knee joint, you can do up to 80. I always do 60. I mean, rarely ever I do 80 because I get the same benefit from 60. If you are doing a small joint, then 20 milligrams. And you can up to do like 40 milligrams for knee osteoarthritis. And that's my usual, and I generally do depomedrol, but radiologists do triamcinolone. But as I told you earlier, that there's nothing on the guidelines that said, okay, you do this one is better than the other.
Awesome.
But the dose is according to the size of the joint.
Phew, it's 101. Everyone has to beaver off to their afternoons. I just want to say thank you, and people are saying thank you as well in the
Thanks a
chat.
lot.
It was
Thanks.
so engaging and so much information, especially some of these things we still see people do, like the chondroitin and glucosamine and whatnot. So thank you so much. Really
Very
appreciate it, and
Denise,
look forward to seeing everyone.
what is the obesity thing that you said that is available?
Oh, we run a course on how to help your patients living with obesity. So
I
I'm currently teaching it with Andrea Milne-Epp for this 4 week, and we're going to be running it again in March. And I think that one's with Dr. Tasneem Sejwani and myself, I think.
Okay.
And so it's a 4 week intensive course on how to do it, all based around the new adult 2020 Canadian obesity guidelines. So
Oh,
if people want to have some tips, please join us. And Marianne, yep, everybody will receive a copy of the webinar as well as the Pearls document that Dr. Akbar is contributing to, with all the tips and things that were sort of mentioned today. Lots of great discussion. We should add in, Andrea, about the AADL. That was just such great information from the hive mind on the call. So thanks everybody for that. Great.
thanks a lot.
Yeah,
Thanks a lot. It's wonderful. Thank you
such a whirlwind. Thank you so much, Dr. Akbar.
so much. Thanks you so much. Thank
Oh, we covered a lot of ground last week and this week, so I'm super looking forward to next week. That's going to be
you.
fantastic.
Thanks a lot. Bye.
Okay.